Hello and welcome to ID Talk, answers from an infectious disease expert. I'm Dr. Sean Elliott, a pediatric infectious disease specialist with Tucson Medical Center, professor emeritus of pediatrics at the University of Arizona College of Medicine, and medical director of infectious diseases and immunizations at the Arizona chapter of the American Academy of Pediatrics. This podcast has been created to answer questions from our chapter's members about the COVID-19 pandemic. This is the week of February 1st, and globally we are at over 380.7 million total cases of COVID-19 and over 5.7 million dead from that infection since the start of the pandemic. In the United States, we continue to rise with our cases. We're now at 75.1 and change million cases with 889,474 deaths as of the day I'm recording this. Pediatric cases from the last report ending last week from the AAP were at over 11.4 million total cases, which is 18.6% of the total cumulative caseload of COVID-19. And here in Arizona, we stand at 375,814 cases reported so far, which is 20.9% of our total cumulative cases. Again, in a telling fashion, the week-to-week percentage of pediatric cases versus the total cases, we're at 22.8%. So standing steady in the low 20s, we've been as high as 30% or almost a third of the total cases, but that back down to just under a quarter of the cases, new cases per week coming from pediatric patients. So today's questions, we have just a couple to go through, and of course we continue to focus on Omicron as the big news. There is also, I think, some rumors about stealth Omicron, so-called. This is not a new variant. This is simply another version, the BA.2 of Omicron. The Omicron that we're all used to, which has been causing havoc for the last month plus, is BA.1. So stealth Omicron is emerging in little clusters in various parts of the world, United Kingdom, Israel, European Union, and here in the States. Not clear yet whether it has entered Arizona airspace, but of course it's only a matter of time. The stealth Omicron is reported to be about 1.5 times as contagious as Omicron, but no more virulent, certainly not causing any higher rate or risk of hospitalization or ICU stay. And it is, where it is existing, causing just many clusters that are identified by the genotyping. So it sounds, I guess, really cool for the media to play on, but in terms of real threat to human health, it's not a major threat. What it might do, just because it is slightly more contagious, is perhaps prolong the tail of recovery from Omicron as we view that in this country. Certainly, and this is important, the deaths associated with Omicron in the United States continue to climb more precipitously than they have in other parts of the world. And current thoughts from the epidemiologists are that this has to do with higher numbers of at-risk adults, especially older adults with comorbidities, who are not either completely vaccinated or vaccinated without boosters and or unfortunately still unvaccinated. So that there's still a good significant third of the United States population that is completely unvaccinated who are continuing to fill the hospitals, both adult and secondly pediatric wards, with fresh cases. Many of those individuals, while they have Omicron, also have significant underlying comorbidities such as COPD, chronic lung disease, cardiac disease, diabetes, which puts them at risk for increases or flares of their underlying comorbidities triggered by the Omicron. So it remains unclear whether Omicron itself is the cause of death or a trigger of related deaths. Certainly in pediatrics, we continue to see upper respiratory disease. Many of our pediatric patients continuing to present with varying degrees of fever or being afebrile, cough, especially a dry, non-productive cough, sore throat, and then the rhinorrhea congestion. So very much turning into what appears to be a typical upper respiratory tract infection, in direct contrast to what we've experienced before with Delta, Alpha, Beta, and some of the other variants that cause a lower respiratory and severe pneumonia type process. So the first question we have has to do with emerging vaccine news for pediatric patients, and I think the big news of the week is that Pfizer on February 1st submitted application to the Food and Drug Administration for emergency use authorization of its mRNA vaccine for children ages 6 months up to 5 years. So you may recall in a previous podcast, data generated by Pfizer for this age group, and it was broken down into two subgroups, was not as overwhelmingly positive as perhaps we would like to think. And actually, if you look at the first of the subset age groups, that being 6 months through, or up to, I should say, 2 years of age, that group of infants actually did quite well with the two-shot, 3 microgram or 1/10 of the adult dose Pfizer vaccine, with equal to or perhaps better than expected efficacy, protection, etc., and so forth. So for those infants, that the two-shot series did well. Unfortunately and surprisingly, that same dose, 3 micrograms or 1/10 of the adult dose, in ages 2 through 4, so up to almost 5 years of age, those toddlers did not achieve the desired target point for efficacy. It doesn't mean they had no protection, it just simply means they did not hit the 90+% that was hoped for. So in that specific age group, the study has been extended by administering a third dose. I'm not sure that I would call that a booster dose because it's being given in a 3 to 4 weeks, or as soon as they can, to the toddlers who received the first 2 doses. But regardless, they're still looking at the impact of that third dose and recruiting data. So you might say, well, why in the heck did they go to the FDA when they have incomplete data? And I think that there are a couple thoughts to share with this. The first is that we all, through the AAP and other national organizations, have been lobbying very vocally for the FDA and the CDC, secondly, to move forward expeditiously on this vaccine indication. It's clear that children under age 5 are significantly being hospitalized with croup-like illnesses, with respiratory failure, with Omicron disease that's putting them in hospital. So they are an at-risk and unvaccinated target of opportunity. And as soon as we can get vaccine into them, perhaps we can then nudge the pandemic further into a state of endemicity and reduce the overall health burden for the population. So that I think the FDA is quite aware of and feeling a lot of intense pressure at the national level and certainly at local level. However, the other thought is that we know that it'll take several weeks for the subcommittee of the FDA and then the CDC and the ACIP, Advisory Committee on Immunization Practices, to review the data. And by the time that an emergency use authorization is extended and that lower dose is delivered and children under age 5 are vaccinated with the first 2 doses, by that time we will be several months down the road and should have the data which Pfizer is actively working on for the third dose. So we'll know by the time we're ready for it whether or not that third dose is A, necessary, and B, successful. So I think this is sort of a future tripping a little bit. It's predicting how things are going to turn out and not wishing to wait for an unfortunate length of time to get going on the first part. So it all kind of makes sense. And again, we'll be very interested to see what the efficacy is. Importantly, the other major part of that story are the safety concerns. And again, in both of those subset categories, 6 months to 2 years, 2 years through 4, there are no safety signals that have emerged that A, are surprises, or B, are significant. So same, mild injection site tenderness, mild fussiness, and those who can verbalize, slight myalgia, headache, etc. But no major concerns, and certainly no unexpected impacts of myocarditis or other autoimmune type processes. So it is entirely possible, maybe even by the time you're listening to this podcast, the FDA will have already considered the data and be rapidly issuing its recommendation for emergency use authorization. Keep in mind that still then goes to consideration to the CDC and then finally is signed off on by Dr. Walensky, the director of the CDC. So I would imagine, and perhaps fingers crossed hope, that in the next 2 weeks after this podcast is released, we should have EUA for a Pfizer mRNA vaccine for kids under age 5. Fingers crossed. Here, we certainly hope so. The second part of the question asked by this submitter is, do we know about boosters for the various age groups? So certainly it's too early to consider booster for 6 months up to age 5. Again, we're still getting a primary EUA just to give the primary vaccine series. We do know that boosters are officially approved for age 16 and up for both Moderna and Pfizer, and then to boost ages 12 and up with Pfizer. The age 5 through 11, it seems like the CDC is leaning that way, but I've not seen official language supporting boosters in that population. Again, probably because we're still recently entering into the primary 2-shot series for those kids. So keep in mind, a booster still needs to be administered 5 months after the second dose. And we've just, in the last 6 weeks or so, maybe 2 months, started to immunize our kids from 5 through 11. So certainly for 12 and up, go for the Pfizer booster, and then ages under that, stay tuned for, I think, more information from the CDC. The second question is, I think, the million-dollar question, and that is, what do I envision an endemic state might look like, and are we there yet, I think is an important question. So depending on one's definition of endemicity, most of the bioepidemiologists and microbiologists out there would suggest that endemic state is when the virus is persistent, ubiquitous, highly infectious, but not significantly dangerous, either from its own decreased virulence or from the impact of highly successful treatment. So, believe it or not, there are many that would suggest that the HIV virus and the AIDS, epidemic, I guess, pandemic, is now an endemic state of affairs because we have such highly successful antiretroviral therapies. That's sort of looking at it from one end of the pool. There are others that point to the 2009 influenza A H1N1 pandemic, that was our last pandemic, that rapidly became endemic because of rapid evolution of vaccine and also rapid evolution of global immunity, either due to natural immunity, the patients got infected and overall did okay, and or were vaccinated, or both. So to this date, we still see influenza A H1N1 circulating in the community, and if one gets it, it is no more serious than a typical flu. And that's not to minimize the flu, and I know all of us who have had the flu say, gosh, that was a pretty mean couple of days. But unlike the early stages of the pandemic with SARS coronavirus 2, where severe infection wound up in the hospital on a ventilator, an endemic state of the COVID-19 pandemic would look like persistence of the virus, infections occurring in vaccinated, boosted individuals that are no more serious than the common cold. That sounds a whole awful lot like what we're seeing with Omicron variant right now. Right, we know that this Omicron variant represents an antigenic shifting event, meaning it has genetic material of an alternate coronavirus, OC43 suggested, and a very original wild type strain or isolate of SARS coronavirus 2. And we know that it targets upper respiratory cells preferentially, and we know that it binds differently, meaning to those upper respiratory cells, than prior variants. So a majority of breakthrough infections in those individuals who are vaccinated and boosted have been much more like a significant cold or a flu-like illness, but without the associated morbidity and mortality, death rates, seen with the former variants. So there is a lot of noise at the global level, World Health Organization, at the federal level from the CDC, certainly from Dr. Fauci, suggesting that it may be that Omicron represents the beginning of the end of the COVID-19 pandemic, and at the very least should be viewed as a COVID-22 or COVID-21, I suppose, to be more accurate. Meaning that what we're experiencing with the Omicron variant is a different kettle of fish than what we've experienced previously with the other variants. And if so, then it may be, since the Omicron variant so far has a significant survival advantage, that this may represent the future. So everyone who's boosted is going to do okay. Certainly, I think we all have friends and colleagues who have been infected with Omicron despite being boosted, and were out for a couple days, as appropriate for isolation, and experiencing upper respiratory symptoms. The fatigue certainly remains quite significant, but overall are doing well. And that, I think, is what the endemic state of COVID, whatever year you want to call it, looks like. In terms of attack rates, I think, unfortunately, while we still have a significant percentage of the United States population and certainly the global population in underdeveloped, under-resourced countries that are unvaccinated completely or under-vaccinated, meaning no booster, that we will continue to have a significant impact on human morbidity and mortality and on hospitalization rates and on ventilator uses and on healthcare resources. That I anticipate is going to be the story for at least the next several months, while we see if and or when the current surge with Omicron and Omicron stealth and all the others will reduce into its overall impact on human health. That will happen, I think, is a certainty. It's just a matter of how long it will take, how long is the tail end, which for many parts of this country we're already on, how long will that tail end last? Are we there yet in Arizona? Personal anecdotal experience is that the hospital I serve is chock full of COVID-19 patients, including pediatric patients. So we're still seeing a significant impact on hospital resources, hospital beds. We continue to scrabble space for new ICU beds, and we have a red letter ventilator shortage in my hospital. So we're not there yet in Arizona, and certainly other parts of the country, especially the southern states, are still experiencing a significant caseload. That said, East Coast, northern parts of the country are on the either plateau phase or starting to have a decrease in their numbers. And so there is hope in sight that at some point in time in the hopefully near future, maybe next several weeks, we'll start to have a decline in our caseload and maybe start to breathe a sigh of relief. If and or when that happens, then I think it'll be a very appropriate time to examine whether Omicron has become our endemic virus. Will there be new variants? Of course there will. I mean, this is natural selection, and the virus has shown an incredible ability to rapidly mutate. The key, though, is will any subsequent variants have any further survival advantage, any selective bias in their favor? And if so, they would have to be much more contagious and also not as virulent. So Omicron really represents that. If you look at it, and this is not to anthropomorphize the virus, but if you look at it from Omicron's perspective, it's very good to be highly contagious, but not to kill off its hosts. So it has a nice, stable, resting ground with which to remain prevalent. So other viruses that have that same pattern will not represent anything new, and thus not a significant competitive advantage over Omicron. So any new variants that emerge would have to have something additional to make them take over and occupy the ecological niche. If so, the predictions are still that immunity based on vaccine plus booster, and certainly those who've been vaccinated, boosted, and infected at some point, will be well protected and help us enter an endemic state. So that's kind of the state of the world as we see it. In terms of a brief overview of interventions, it's of course, we can hear about the disease. It's good to hear what we can do about it. It still remains true that of the monoclonal antibodies, the sotrovimab is the one product which still retains efficacy against Omicron and stealth Omicron as well. Unfortunately, it is still quite limited in supply, and although there will be children ages 12 and up with comorbidities who meet CDC criteria to get sotrovimab, it is, I think, unclear that there are infusion centers and availability for them to actually receive it. So that said, if you do have a kid 12 and up and over 40 kilos with chronic lung disease, diabetes, cardiopulmonary respiratory distress, on a mechanical intervention, and chronic asthma with use of a daily controller medication, it's a very broad definition, which I think will include a fair number of our asthmatics. Those kids would qualify if infected with Omicron or whatever variant comes down the road to get sotrovimab. The challenge, of course, is to find a place to administer it. And to look for availability, certainly you can look at data trackers from the Arizona Department of Health Services. The CDC as well maintains that. And you can access all of these through the AAP websites and also through your local county health department and the AzAAP. So that's the monoclonal antibodies. In terms of the antiviral treatments, remdesivir retains efficacy in those patients who are sick but not too sick. Meaning, if they are exposed, low-level infected, there is a 3-day outpatient series of remdesivir injections that does appear to prevent escalation to hospitalization, which is great, but you still have to go to an infusion center or someplace to get that. And also for those who are hospitalized on oxygen, even up to high-flow nasal cannula oxygen, but not escalating to require non-invasive or invasive ventilation, those are individuals that would benefit from a 5-day IV course of remdesivir. So So that retains its protective or its helpful impact on actively infected patients. So too the Merck drug molnupiravir, which retains its apparently 30-ish% efficacy even in the face of Omicron, and that's been recently demonstrated by Merck. So again, oral medication for those who are infected and mildly ill as an outpatient. The drug, of course, that has the best efficacy is the one from Pfizer named Paxlovid. It's a combination product of two protease inhibitors, and that has been confirmed to retain efficacy against Omicron and apparently even stealth Omicron. So that drug also is oral, outpatient, high efficacy rates to protect progression of disease and need for hospitalization, ICU, or ventilation in patients who are mildly infected. Both of those oral medications are approved by emergency use authorization for ages 12 and up. So there are options. The challenge, once again, is to find them. And also in Arizona, and I think most parts of the rest of the country, there remain, unfortunately, limited supplies of both molnupiravir and the Paxlovid combination drug. And so in Arizona, at least, we've now broadened inclusion criteria to category 2, which is age 50 years of age and up with significant underlying comorbidities. So as of right now, kids don't qualify. But at some point in time, as continued doses are manufactured and delivered to Arizona and other parts of the country, then we can anticipate the category or phase 3 release, which will be all patients 12 and up with underlying comorbidities or risk for severe disease. So that is where we stand. No new news on dexamethasone. That retains its impact, as do other systemic steroids for patients who are hospitalized with active respiratory disease. Again, it's interesting in pediatrics. More of our pediatric patients admitted are having upper respiratory disease and perhaps a flare of underlying health concerns and or having croup. And these are kids in whom we would be considering dexamethasone anyway for the airway inflammation management. So it's sort of two birds, one stone, or one steroid, I guess you could say. But in any event, that there is no new news to suggest any different approach at this point. So that's where we stay. That's where we stand. Once again, thank you for listening to ID Talk. AzAAP members can submit questions for future episodes to covid@azaap.org. The AzAAP would like to acknowledge the generous support of this podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to COVID-19 in Arizona, or to learn how to become a member, please visit us at azaap.org. And in the meantime, and as always, hang in there, folks. Keep fingers crossed for an endemic phase and for continued plateau and then decline in our own experience with the Omicron virus. Hang in there, y'all.